and this presentation is made in 2024 with ageism in the NHS as the theme. Why did I make this presentation? It's because of a case, obviously. Harriet is the lady in question. So who am I? I am an interventional cardiologist in London. I run the structural heart program at Imperial College Healthcare NHS Trust at the Hammersmith Hospital. And I have a private practice in London, London Cardiovascular Clinic. I'm a patient advocate first and foremost, and the patient is the center of everything that I do. It took some persuading to do what I felt was the right thing, and I still believe it is the right thing. So is age a good thing or not? As we get older, our comorbidities increase, and increasingly we get weaker, but we also get wiser, and there is wisdom in age. Not every patient will be suitable for every intervention, and that goes at the age of 40, just as it does at the age of 100. So the case in question is not Queen Elizabeth, the Queen Mother, who at the age of 101 made her final appearance in public, but of Harriet, who was also 101. And you can catch her on YouTube after her procedure. So I've already revealed that we did do something to her. She presented in May of 2024 with a heart failure admission. She'd been getting worse and worse breathlessness and leg swelling, and an echocardiogram on that admission showed critical aortic stenosis and good left ventricular function. With 4 weeks of diuretic therapy, she lost 15 kilos of water. With antibiotics, her cellulitis and thereby her confusion also got better. She saw the first cardiology consultant, one of my colleagues in heart failure, at the end of May, who saw her and offered her a TAVI for her critical aortic stenosis. Harriet declined, but a few days later, she thought about it and reconsidered the offer, and was then seen by a care of the elderly consultant, that's consultant number 2, who also felt intervention was appropriate. I was consultant number 5 to see her. Consultant number 4 was an imaging consultant, and our very senior fellow, who is now one of our consultant colleagues, was doctor number 3 to have seen her from the cardiology team. So far, 5 team members have felt that this was an appropriate thing to offer a TAVI at the age of 101. What madness. However, there was a lot of locker room talk. And when colleagues found out that we were about to treat a 101-year-old, there was quite a lot of consternation and concern about whether this was the right thing to do. So I'll share with you that the imaging consultant went back and saw her. That was consultant 4. And a further care of the elderly consultant saw her and again was supportive of TAVI. And it was at that stage that we discussed her case at our joint cardiology cardiothoracic meeting, the JCC, where both surgeons and physicians, all trained in cardiovascular disease, discussed the cases. I presented the case, and as might be expected, having seen her and seen how remarkable Harriet was, very strongly advocated for intervention and presented the evidence base. I took a stand. It has to be said that some people thought I was mad. Ageism is not allowed in the NHS. In 2012, there's a very clear statement that said, actually, you could be taken to court if you bias someone just because of their age and not their clinical condition. But in 2013, the King's Fund found that ageism was still rife. The NHS Constitution says we have to provide a comprehensive service with a duty of care, and the Equality Act specifically states that you cannot ban treatment just because of their age or assumptions made on the back of their age. So what is the point of doing anything at 101? Well, these are the life expectancy tables. In the UK, for age 100, on average, you're going to get about 2 years of life. That means 50% will live longer than 2 years and 50% will live shorter than 2 years. What about at 80? No one would quibble about doing a TAVI at 80. Well, at 80, you get between 8 and 9 years of extra life. It has to be said there was a fair amount of discussion at the JCC. There was a lot of opinion-based rhetoric, I have to say, but also I showed the data. And it's good to have robust discussions amongst senior clinical colleagues when there is no hard and fast evidence base, or is there? So perhaps we've forgotten history. It was at our own institution that in 2017 we treated a 98-year-old who, by the way, was much more frail than my 101-year-old. He lived to 104, and the family remain eternally grateful. We sorted him out. We did a TAVI, and he got home and survived another 5 to 6 years. Of course, in the USA, they've done a 107-year-old. In Japan, treating people in their 90s is fairly routine because their population can live to a ripe old age. And even in Birmingham, 101-year-old was treated in 2023, a year before our patient. But what are the outcomes? We should not be opinion-based. We should be data-based. It's very clear that if this non-surgical candidate was left alone, then her mortality was at least 50% at 1 year. But what if we treat an over 90-year-old? Well, the data is it's about 7% 30-day mortality and probably about 20% 1 year mortality. I will remind you that partner 1B trial, the first data on TAVI, treated people who were absolutely not surgical candidates and had a 50% 1 year mortality. By doing TAVI, it reduced to 30% 1 year mortality. That is a 20% absolute risk reduction in mortality within a year. That's an astronomical reduction in the death rate, and that's what we would expect for Harriet. The assessment was detailed. The heart failure consultant offered TAVI. Harriet initially declined, then agreed. The imaging consultant offered TAVI. She agreed. I and the TAVI team offered TAVI, and she agreed. A further care of the elderly doctor saw her and agreed TAVI. And finally, the surgical liaison care of the elderly doctor saw her and felt she was a candidate for TAVI. The impression was that she was an independent lady with minimum comorbidities, and apart from the blood that needed to be looked at by the hematologist, there was no reason to prevent TAVI being performed. Harriet is adamant she wants to go ahead with the procedure despite the risk because she actually does not want to deteriorate at home and leave her independent living. The imaging consultant who saw her initially and was on the call with me was initially persuaded of TAVI and then was persuaded that maybe a step too far. But having had the JCC discussion and gone back to seeing her, again felt that age alone could possibly not be an absolute contraindication to TAVI. And we took her to our aortic MDT after our JCC. I will share with you some of the arguments that were presented at our joint cardiology cardiothoracic meeting. She's 101, but she has 2 years to go on average, perhaps longer. The program is at risk. Well, it is our program, and we do high-risk cases, but this patient has possibly the most to gain because she has the most to lose. What are we doing? Can the NHS actually afford this when ambulances are queuing up? We're running out of money. Well, me not treating Harriet is not going to get this young cancer patient her cancer treatment, which the NHS would otherwise be able to do because I hadn't treated Harriet. That does not stack up. I am not the health secretary, luckily, because that is a difficult job. How will you spend your money? If I was told I cannot treat anyone over 90 or 95 or 100, then I won't do it. But there is no such ban because actually it would be illegal. Will that £35,000 on a TAVI be well spent? I think probably yes, because if Harriet dies, well, death is very cheap for the NHS. If she died tomorrow, there would be no cost to the NHS at all. But if she comes into hospital with heart failure, then she'll be £1,000 a day. And she already spent a month in hospital with heart failure, so that's at least £25,000 before I got anywhere near her. So what is my role? My role is to assess the patient in front of me and offer what I think is the best treatment possible. So after a 30-minute discussion, where it has to be said there was not universal agreement, then it was agreed that if the patient accepted the risk of TAVI and the TAVI was felt to be technically feasible, that we can proceed to TAVI. I think that was the best outcome that I could have achieved there, because taking the history again, interestingly, she'd had a heart failure admission before. She was 99 at that time. Apparently, she declined investigations, but I'm not so sure that she was offered it in the right way, and certainly the TAVI team had never heard about her. On this admission, the valve had become critically narrowed. The BNP, which I don't really like, was not very high, despite the fact she presented with heart failure, and the CT scan showed that TAVI was anatomically possible. So, she also has atrial fibrillation and has quite a high risk of pacing because she has an abnormal ECG with right bundle branch block and left axis deviation. She has hypertension and hyperlipidemia. She also had this blood problem and had been on long-term ciprofloxacin, but the hematologist said you can just cover that with GCSF and there'll be no problem. The lung nodule is of no issue. It's often seen in older people and was not for any follow-up. And her cellulitis and delirium had been treated with antibiotics with no confusion anymore. The aortic MDT felt that if we'd given tablets alone, she would probably not make it to the end of 2024. A balloon valvuloplasty was probably just as risky as a TAVI, and a TAVI would carry a 10% risk of death, stroke, and very high risk of pacemaker on top of that. Now, 2 TAVI operators, including myself, felt that if a pacemaker was going to be needed, we could do it at the same time in the cath lab after the TAVI procedure. And 2 of us felt that a pacemaker should be done in advance. But I argued that a 101-year-old should only have 1 trip to the cardiac cath lab and not 2. And here is the TAVI procedure. It was done in June of 2024. The sheath was a little challenging to put in. We've then lined up and put a temporary pacemaker in. The temporary pacemaker, I think, good idea here. We often don't put one in, but with the right bundle branch block, left axis deviation, a high risk of needing a permanent pacemaker, a temporary pacemaker seemed a good call. We line up the valve with the annulus. The CT predicts the angle in the cath lab, and you can see we've done a double injection. So I really use minimum amounts of dye to actually try and do the TAVI procedure. And remember, Harriet is awake. She's got local anesthesia and some sedation and is awake during this procedure. So here's the valve being lined up. The eagle-eyed might spot a slightly loosened line on this Edwards valve. This is a balloon expanded valve, and the red arrow marks where we want to place that loosened line along the annulus. So when we blow the balloon up and deploy the valve is as high as possible. And here is a pretty perfect height for someone at high risk of a pacemaker. If you go too low, the pacing rate goes up. If you go too high, obviously the valve might fly off. That would not be good. But this, I think, is an ideal position for Harriet. So what's happened with the procedure? We always measure the hemodynamics and the ECG before and after. The ECG has remained unchanged. We may well be getting away without a pacemaker, but the critical aortic stenosis has turned into no gradient at all. So a fantastic result from the Edwards TAVI. However, she's gone back up to the ward, and 4 hours later, she's come into complete heart block. So that pacemaker was put in. She got her second trip to the cath lab, and she got her pacemaker the same day. So in summary then, she's had an admission on the 23rd of May. She's had a TAVI on the 17th of June, so 4 weeks later. And then about 5 days after that, she's gone home. You can see who she is because I recorded a little chat with her. And this is a YouTube link to that, which I'll also put in the comments below this video. She's a silver surfer. She's independent in her activities of daily living before she came into hospital. She goes to church every Sunday. She lives independently with her sister, her younger sister, a few years younger than her. 1 month later, she was doing well with some edema and a mouth ulcer. The pacemaker and the valve were doing very well. So we think we've got away with it. Of course, she is 101, and those poor ulcers in the mouth reduced her oral intake, so she had a short stay in hospital, not heart failure, but really dehydrated. And then she's at home again and still surviving. There's a saying in the UK that buses don't come in ones, they come in twos or threes. The next bus is going to come along. Well, a 102-year-old came in within a few weeks of Harriet. Chest pain, collapse, critical aortic stenosis, but now rather poor left ventricular function, so actually in a worse state than Harriet. We discussed her at our big meeting again. And this time there wasn't such a deep discussion. We recalled the discussion from the time before of a similar age patient. And again, if the patient accepts the risk and it's anatomically feasible to do the TAVI, well, then the TAVI team were authorized to proceed to do the TAVI. So for her, the 102-year-old, the admission was on the 11th. Within 2 weeks, she'd had her TAVI procedure, and a few days later, she went home. So is there ageism in the NHS? Yes, there is. Definitely alive and kicking, but education can lead to change. And I think leadership is key. It's very easy to have an opinion, but if you show the evidence and take your team with you, then you have a safe and effective procedure. No mavericks allowed, but team-based learning very appropriate. You are the patient's advocate. You know the patient more than those who've never seen the patient. There is no I in team and there's no I in leader, but a team needs to have a leader and a patient needs a patient advocate. And hopefully this case is illustrative of the fact that age is a mere number. If I'm 101, if I'm lucky enough to be 101 and my marbles are not there and I'm in a nursing home, I absolutely do not want ridiculous treatment. But if I'm independent at home, leading a good quality life, then my age should not stop me getting the treatment that's needed to return me to health. You can contact me via my private PA at drmalikpa@onewellbeck.com or Sharon Kebble, my NHS PA at Hammersmith Hospital. Hopefully that's provided some learning for you. All the very best.